Our first two researchers are going to present on social isolation and belonging. And so really excited about this work. Their emergent research efforts at the University of Arizona, and they explore in that research and those research practices the intersection, again, of isolation, belonging, and the impacts on both aging, wellness, and the health span. And while these researchers are working with specific populations, as we'll hear about when they do their presentations, I think you'll see that their findings have emergent results that are broadly, could be extrapolated broadly to other applications in ways that we're really excited about. And I've been energized by and learning about them and their work. To set the stage for this work, let's see, that's me. And our presenters today, we'll introduce them again soon, are Kelly Palmer, Dr. Kelly Palmer from the University of Arizona. Jovier Evans will help discuss. And then Yumi Shirai, Dr. Yumi Shirai from the University of Arizona, and Dr. Margaret Nigrin will help discuss as well. We'll have space for questions. But to set the stage for this work, and we've heard a little bit about this from Lindsay earlier about the loneliness epidemic in the United States. I wanted to point to a couple of recent publications that underscore what I think of the essential nature of the inquiries of the two researchers. Earlier in May, as we heard, the Office of the Surgeon General issued an 88-page advisory called Our Epidemic of Loneliness and Isolation, drawing on decades of research in a range of disciplines, including sociology, psychology, neuroscience, political science, economics, public health, and among others. The advisory outlines the health consequences for loneliness and our frayed social fabric and recommends actions to begin to restore connections. I've pulled a few graphics from the advisory here to help illustrate. So in this first one, a range of general indicators demonstrates that this connection is multifaceted, that it is legible in a range of contexts and circumstances with similar outcomes. So for instance, the first little frame on the right that has the trend that goes up, it shows the rise in hours on average that social isolation has increased with a demonstrable spike in the last 7 years. One would wish that that might be a chart of my retirement, but it is not that at all. It's unfortunately much more nefarious and scary for what it represents. Much more social isolation, specifically in the last 6 to 7 years. Other indicators on this frame and panel include household social engagement is down 5 hours per month on average. And so that demonstrates how we connect with the people in our homes, our families, the people with whom we live, that we're doing less of that we're less connected, spending less time together in that space where essentially that might be designed for how we connect to each other. Other indicators are around companionship or friendship, and that those are also down by something like 14 hours per month, the study finds, the advisory shares. This might be shared leisure that we organize with friends, how we connect with companions in a happy hour, or to play sports together, or to attend events together. All of these are down, or the amount of isolation has grown, and the consequences have been dramatic. So collectively, there's clear data here that we are not connecting with each other as much as we used to. And at any given time, 1 out of 2 Americans, the study finds, is experiencing a measurable level of loneliness that can be documented. It occurs across the spectrum, so it's not particular kinds of people that experience this that they found so far. I think more research is required, and they're excited to explore this further, but they find that it is across rich or poor, throughout genders, across ages, and in rural settings. So it's loneliness that is equitable in a way, but the wrong kind of equity that we're looking for. We're looking for other kinds of equity. The consequences are wide-ranging and dramatic, and as this next chart indicates, and this is again from the study as well, and so lacking a social connection is dangerous to health. And in terms of health impacts and issues, it can be as dangerous as smoking 15 cigarettes a day, the study finds, far more dangerous than obesity or a lack of physical activity. Broadly, the advisory asserts that our lack of feeling like we belong, of feeling alone, or even sick, or even angry, can measurably lead to greater instances of cardiovascular disease, dementia, and stroke, as well as other outcomes like depression, anxiety, and even in some cases premature death. Beyond health, there are measurable impacts on our economic well-being. When we're not well, it's difficult to go to work. And we can see the impacts that it can have in our cultural lives or even in the political lives that we lead. And the study gives 6 strategies for thinking about how we can counteract the epidemic of loneliness, including strengthening the social infrastructure. This is the first one here. And so this can happen in a range of ways, some of which are more obvious. Things like how we make investments in our workplaces and in our schools, how we invest in cultural programs and experiences. Also things like the built environment, how architecture can help us foster greater connection to one another, and how we can use that as a tool to counteract this problem. Another is enacting pro-connection public policies. So adopting connection in all policies, seeking harm reduction wherever possible, mobilizing the health sector, so training healthcare providers and seeking out interventions, some of which are already beginning to happen on local levels in ways that have been positive. Reforming the digital environments to be safer, to be more trustworthy, and that can support pro-connection uses of digitality. Deepening our knowledge, so coordinating new research efforts and investments in this research, and then building a culture of connection, how we expand the conversation into the civic space, again, into schools and beyond. It feels to me a lot like Dr. Palmer and Dr. Shirai's work is in the vanguard as this came out, although I don't think they coordinated with the Surgeon General. They might have. So of course, there were calls for belonging far beyond the Surgeon General's recent advisory. One of the ones that I love and I'm interested in, it comes from a group of artists who in the early 2000s had some interest in notions of belonging. They were interested in a government agency that they thought should exist and that didn't exist. And so they decided as a group of artists to create the Office of Arts and Culture as a federal agency, but not really as a federal agency, just as a group of artists that created a website. And they created in that essential tenets that they wanted to see begin to be implemented. And one of those was about belonging. And that was their core foundational founding, that belonging was our central cultural deficit. And that without a greater sense of belonging, that we were in trouble for the civic good of the country and for the broad polity. But as we can see in the Surgeon General's report, the health impacts are increasingly clear, incredibly legible, and require response. A final recent study that I wanted to point to, just to set the stage, this is about that, the prior point. The final study is from a group called Over Zero, which has recently issued a report, and they're a think tank. The report, Over Zero in general does research on dynamics of identity-based division and even identity-based violence. And so they issued a report called The Power of Belonging in the U.S. Today. And this attempts to address what they think of as the essential conundrum. And this is a quote from them. It's, "Belonging is an essential human need, one that is linked to our most complex challenges over time. Without a sense of belonging, individuals and communities suffer. With it, they thrive. But because belonging is so difficult to measure, it is often ignored in efforts to address deep fractures in society." So this group has worked to create something that they call the Belonging Barometer, which is an applicable tool, a series of questions that they designed to help try to begin to measure and quantify how much belonging someone experiences or feels. This work of belonging, experiences of belonging, of course, is work that is never done. And so one can't quite say, we now belong, that's done, we click the box. It's ongoing work, and the journey is as much the result as the study. So they find, and they have a couple of key findings here, belonging is complex and multifaceted. So in applying this belonging barometer, these are what they're seeing as results. It's difficult. It's about the quality of fit one feels with their surroundings, and it's about being in a kind of right relationship. What tools do we use that help engender those right relationships? That belonging is vital for American society. That there's a range of ways. Again, they find that this impacts health in the same ways that the other studies have shown. That it also, of course, affects productivity in workplaces. That it can lead to greater trust and civic connection in our local communities if we feel experiences of belonging, and that it can help in how we participate in democratic processes if we feel like we belong in our countries, in our states, in our cities. A majority of Americans report non-belonging or experiences of non-belonging. This parallels the sense of greater understandings of loneliness. Socioeconomic status and systemic factors are strongly associated with belonging. So when you layer this with structural inequities, such as something like the history of redlining in this country, or communities that experience xenophobia or racism, these exacerbate the ability to feel like one belongs or how one exists. A large percentage of Americans feel that they are treated as less than, suggesting some challenges in our civic norms and how we interact with each other. Belonging and diversity are interdependent, they find in their study. Americans with one or more diverse friends reported higher levels of overall friendship and belonging in general. Moreover, Americans living in diverse neighborhoods reported less marginalization, more openness to demographic change. And this is true as the country begins to change and how the future that we're all going to have together. And the last part is that belonging itself is attainable and that interventions are already showing some success as this goes forward. So I wanted to mention all of these as ways to set the stage for the research that you're going to hear from the two researchers at the University of Arizona. I'm very excited now to welcome up Dr. Kelly Palmer, who's an assistant professor in the Mel and Enid Zuckerman College of Public Health. And I'm going to, let's see, this slide is the one that I want to show, and we'll jump back to the introduction. An associate director of the UAHS Center for Health Disparities Research. Dr. Palmer is going to present on her research project, which is virtual experiences to reduce loneliness and psychosocial distress among older Black church members. It's a beautiful and amazing study. I want to welcome Dr. Palmer up to come speak with us.
Okay, can you hear me? Is this thing on? All right. So like Lindsay, I'm long-winded, but I talk fast. And Carla's going to keep me accountable here. And I'm going to try to maneuver all the technologies and how to go old school and print out some papers here. Greetings, I'm Kelly Palmer. My pronouns are she, her, ella. I would like to thank the University of Arizona Health Sciences, Innovations, and Healthy Aging Summit organizers for inviting me here today. Thank you, Tyler, for the introduction. I'm going to share with you all my project, Virtual Experiences to Reduce Loneliness and Psychosocial Distress Among Older Black Church Members. But first, I'd like to give a land acknowledgement. We respectfully acknowledge the University of Arizona is on the land and territories of indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the Autumn and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and indigenous communities through education offerings, partnerships, and community service. Washington, D.C. sits on the ancestral lands of the Anacostans and the neighboring Piscataway and Pamunkey. I looked that up, so I apologize if I mispronounced that. Peoples, we gratefully acknowledge the Native peoples on whose ancestral homelands we gather, as well as the diverse and vibrant Native communities who make their home here today. We pay respects to their elders, past and present. And finally, a labor acknowledgement. We respectfully acknowledge the enslaved people, primarily of African descent, who provided exploited labor on which this country was built with little to no recognition. Today, we are indebted to their labor and the labor of many Black and brown bodies that continue to work in the shadows for our collective benefit. As the African proverb says, if you want to go fast, go alone. If you want to go far, go together. And this proverb is befitting because the intervention for this project is all about togetherness. But what I will share with you also today is the critical collaborations that is at the core of this study. So I have a bit of a disclaimer or a spoiler alert. I am not an aging researcher. So in 2022, I was a new assistant professor embarking on my new career in research, primarily looking at diabetes prevention, cervical cancer screening through a health promotion lens. I consider myself a settings-based researcher that focuses on culturally informed interventions, asset-based approaches. And then, so here comes Dr. Carter. And Dr. Carter is a professor in Africana Studies and the director of the Center for Digital Humanities. And I got to learn all about what digital humanities means. And Dr. Carter invited myself and Dr. Erica Galt, who is an associate professor in Africana Studies, who focuses on Black religiosity. And we had a meeting to discuss how we could come together and collaborate to help our local aging Black community. And so I'm coming with my health promotion settings-based lens. Dr. Carter has this amazing lab full of cool and amazing technology, and he's an expert in virtual reality. And then Dr. Galt is an expert in Black religiosity. So after a very long conversation, and again, this is probably within the first 30 days of being an assistant professor, we came up with this project idea. And we submitted for the grant, and I'm very thankful to Research, Innovation, and Impact and Healthy Innovation Program for awarding us this grant to do this project. Okay, so Tyler already gave us a lot of background about the significance and detriment of social isolation and loneliness on the aging population. But as an asset-based approach, I want to talk about the fact that Black people in general have well-established social networks which are protective against isolation and loneliness. Moreover, Black people that receive social support from friends and family are less likely to experience symptoms of psychosocial distress. Among older Black adults, being socially connected is associated with decreased loneliness and better mental and physical health. Aspects of spirituality and religiosity are progressively being recognized as a pathway to health and well-being, mostly as a foundation of support and a positive coping practice. Recently, spirituality has been identified as an important dimension of quality of life, and compared with other racial groups and younger adults, older Black adults have the highest levels of engagement in religious activity going to church. Black church members may attain health benefits from their spiritual and religious beliefs, as well as their social network and personal relationships within the church. This religious social network, as well as church attendance for older Black adults, is vital to preventing social isolation and loneliness. But then COVID happened, and churches had to close. And risk mitigation strategies caused many churches to shift to virtual services. Well, this was great, and the churches were very thankful that they had the capacity to deliver their services via Zoom and Facebook Live and YouTube, but there's a lack of connection and an immersive aspect when you're just viewing your services online or through a computer or a television. And so while things have since opened back up, many older church members have not returned to in-person services or prefer or have concerns about being in person. And this threatens the social connectedness for older Black church members. So to this end, our study seeks to develop and implement a culturally responsive, spirituality, religiosity-based virtual experiences to increase social connectedness and physical activity and reduce loneliness, social isolation, and psychosocial distress among older Black church members. And here are our specific aims, which include measuring the feasibility of implementing this intervention in churches. So as I mentioned, Dr. Carter is leading the development of the virtual reality intervention using 360-degree cameras, pre-recorded and licensed content, as well as content from the headset developers. The virtual experiences will be uploaded and pushed out to virtual reality headsets. And Dr. Carter has traveled the world filming locations. Earlier this year, he was in Paris, filming locations there with some of his students. And so our participants will be able to take virtual field trips to Paris. I want to give a huge shout out to our students who have worked diligently on developing the intervention. Many of our students are part of the Center for Digital Humanities. Some of the students are working on our outcomes evaluation. They're all so talented. So please remember these faces and names because they are the future of technology-based innovation. Our intervention will include a menu of virtual experiences. Content options will include live streamed and recorded church services, virtual field trips, low impact physical activity, and social activities. Participants will have autonomy in choosing what virtual reality experiences they participate in, to what extent, and how often. So this is not going to be very prescriptive. We're really just looking at feasibility. Will they do it? Do they enjoy doing it? Do they want to continue doing it? I'm doing really good on time. I'm really proud of myself. Our community collaborations are at the core of this project. The Interdenominational Ministerial Alliance Health and Wellness Committee is our primary community partner. The IMA members selected and secured agreements from participating churches in Tucson and advised us on recruitment strategies, study design, and other study protocol elements. We're working with 4 local churches: Ideal, Rising Star, Grace Temple, and Tucson Sharon. And they're all really excited about the project. It's been a wonderful experience just talking through the project, getting their input, their feedback, and hearing their enthusiasm. Here you can see members of the IMA trying on the virtual reality headsets. They took great consideration in deciphering the ease of putting on the headsets, the weight of the headsets, the ability for someone who wears glasses to wear the headsets. They took all of this into consideration of their older church members when selecting the proper headsets for the study. And also here you can see the Center for Digital Humanities team at Rising Star Church doing a site assessment. So they're assessing the church's broadband capabilities, what it'll look like to place the cameras in different parts of the sanctuary, and what that'll look like in the virtual reality space. So per our aims, we will conduct pre and post intervention assessments related to our outcomes. And here's a breakdown of the assessments at each time point. I won't read them through. But through the VR platform, we will be able to download data such as usage, time spent viewing experiences, so we'll be able to get directly from the devices what the participants are accessing other than church services, how much time they're spending in each activity. We'll be able to do eye tracking to see what they're looking at within the virtual space, particular zones that they're focusing on within a 360-degree experience, the number of views for each experience. And through those analytics built into the headset, we'll be able to see if the participants are engaging within the virtual space. We'll be able to capture information on which modules they access and the frequency of access. And then, of course, we'll do a bunch of surveys and ask them how they liked it. So in discussing this study with the IMA Health and Wellness Committee and the church pastors, we were able to gather some formative data on the need and the desire for this project. Because I don't believe in building an intervention and then shoving it down the throats of the community, right? So we wanted to really partner with our community partners, collaborate, get their input, and really make sure that this was something that they wanted to embark on. So I'll share a few quotes that highlight the enthusiasm that was expressed to us. So one of our members of the IMA committee said, this is needed. No one is thinking about our elders. They are often forgotten. So a lot of times the churches are approached to do research projects, and it's focused on, weight loss, diabetes prevention, the things that I normally would participate in, but nothing that's ever directly for the elders of the church. So they're really excited to see something for the elders. One of the pastors said that just because we are older doesn't mean we can't try new things. I use virtual reality myself and I love it. So I was really excited to hear the pastor talk about the fact that he himself uses virtual reality, and he was so excited for the rest of his older church members to also get a chance to try it out. And another pastor said, we should think about offering this to others. We have church members who are sick, moms at home with babies, and younger members who prefer to worship from home. So they're already thinking ahead and seeing how we can expand this to other members of their church, other demographics and populations who would also benefit from being able to attend church from home in a virtual space in a more immersive experience. And so I'm excited about the project, the collaborations, and this innovative intervention to address the digital divide while increasing social connectedness for older Black church members. Thank you.
Thanks so much, Dr. Palmer. I want to invite up Dr. Jovier Evans, who's going to help discuss and respond. Dr. Evans is the branch chief of the Geriatrics and Aging Process Research Branch for the National Institute of Mental Health. This is a little bit more about Jovier. Welcome. Come on up.
Oh, thank you.
You've got a microphone, don't you?
I do.
Yeah. Okay. Perfect.
Can everybody hear me? Good, good. As he said, I'm Jovier Evans. Thank you for inviting me to this interesting summit today. As he said, I'm the branch chief of the Geriatrics and Aging Processes Research Branch at the National Institute of Mental Health. And in our branch, we specifically focus on mental disorders of late life and how to think about risk and resilience factors as they relate to all of these things across the age span, particularly with regard to primarily things about depression and anxiety among older adults, but also what can you do to prevent other kinds of neuropsychiatric problems related to Alzheimer's disease and other dementias, which may cause a lot of people to end up in higher levels of care and or need higher levels of care. So I'm just gonna, I have no slides, so how do I get rid of this picture? Yeah. Thank you very much. Thank you. I don't have a headshot or anything, so I took that outside or something. But I wanted to start by talking about the study that Dr. Palmer just presented, and I want to highlight some of the strengths and or benefits to the work that I think we're all trying to promote at NIMH around both collaborative based participatory research, as well as the need to think about multidisciplinary and cross-disciplinary approaches to the study of these sorts of problems. So as you said, you're working with a digital health intervention expert, you are a public health expert, and you're working with someone who understands the community at large. We do need people to think about team-related science and how you bring different people together to approach problems to be more both innovative, but also more effective to reach people where they are. So what I liked about what you talked about with regard to the study is that you're focusing on a group of people who are connected. So at some level, you're looking at how do you promote resilience among the people you see, because these people do have that social connection of the church. But I also thought about those people you mentioned in your last, I guess, quote, the people who aren't connected. So what do you do for the elders who may not actually be involved in the congregation, or those people who aren't coming to church? How do you get to those people, because those people might be at higher risk for other negative outcomes? I think the other great thing about what you were talking about was, what's the active ingredient? Is it the VR headset? I've never done that. And every time I hear people talk about it, I think it's fascinating, but is that really what's important? Or is it the connection of, say, your RAs who meet with the people to talk about, this is how we're gonna use it, and that added social connection that you talked about with regard to those interactions. And so we have been interested, as you said, around the interplay of both social disconnection and social isolation and their impacts not only on physical health, but mental health. We held a workshop, I guess, in 2020 to look at the role of social disconnection as it relates to the risk of suicide, particularly among older adults. And I'm not sure if a lot of you are aware, but older men particularly are at great risk for suicide. So what is it that we could do with regard to the research studies we support that would look at aspects of both not only social disconnection, but social isolation and loneliness, because they're not all the same thing. So if you can disaggregate what sorts of things relate to mechanisms of dysfunction or mechanisms of resilience, what can you support? So we have an active notice of funding opportunity announcement out right now in this space, but that was prior to the COVID-19 pandemic. And I think the pandemic has exacerbated the negative effects of isolation, as well as provided different opportunities, though, for the establishment of technologies to reach out to people. So telehealth is now a huge boost with regard to healthcare in this country. And, you know, there have been efforts. I was just at a meeting last week of the National Academies to make sure that telehealth is covered by Medicare and will be paid for by Medicare to continue in the future. So to think about how do you get to people where they are. And in the area of mental health in general, we have fewer older adult providers who are trained with regard to geriatric mental health, but we have a lack of mental health providers in general. So how do we think about alternative strategies to provide care or extend the wealth of care or the reach of care by things like peer supports, peer networks to help with regard to the delivery of care, and how do you extend those sorts of things? So the work you're doing points to some of those things with regard to both the use of technology as well as thoughts about how to extend reach, I think primarily. And so I just wanted to end with a little plug that our branch exists. We're interested to work with people who are interested in this kind of work, and I'd be happy to talk to people for the rest of the day about those sorts of things. So thank you.
Thanks, Dr. Evans. If you want to join Dr. Palmer here, we have time for a few questions from the audience. We have questions. I know that Tara's going to come around with the mic if there's questions from the room, and then we also can receive questions online. So if you're online and have a question about this research, please ask. Please, yeah.
Hi, Lee Ryan, University of Arizona. Really nice talk, and thank you for the discussion. I had a question about the technology as well. So not a lot of older adults have that technology. I know you're providing it for them. We also know that because of vestibular changes that quite a number of older adults who use VR actually have a very negative response to it. So there's reasons why it might be a barrier. So I was wondering in your study whether you're also going to be looking to see whether the VR is necessary. Is it just as good to be watching these same things, say, on your smartphone or on Zoom on your computer?
Yeah, so a couple of things that we did take into consideration are some of the adverse effects of using VR. Can you all hear me still? And so that was one of the reasons it was really important to have the IMA members come and help us select the VR headsets. Dr. Carter has almost like a showroom full of virtual reality technologies, and so we really had them kind of go through all of these different kind of factors in picking out the headsets. And then as part of our evaluation, we'll be checking in with the participants to see if they're having any adverse effects, to understand if they're not using the technology right. So if they're saying like, yeah, it's making me dizzy, or just different things that we know can come from using virtual reality. This study is too small to really do a comparison, but we're hoping with some funding that in the future we could do that we could do a larger trial where we could compare maybe watching a streamed version on YouTube or something like that to using virtual reality. Our hypothesis is that more immersive experience where someone can feel like they're sitting in the sanctuary and they can turn and look at a fellow church member will provide a different type of experience than just kind of that static approach of watching it online. But we'll see. So it's just part of our evaluation, and we're excited to see what happens.
Gotcha.
One other
Yes.
comment and follow-up, Lee and I were thinking, Carol Barnes, University of Arizona, are thinking along the same lines. I am going to be 74 this year, and I did an experiment at the University of Arizona using these headsets and so forth, and it takes a while, and I know that other individuals had to not participate in the experiment because of vestibular issues. But I also think that movement is probably really important. Are these immersive and you move around, you walk around with them on, or are they you're just tracking eye movements and so forth? because we know parts of the brain, we're neuroscientists, so we know that parts of the brain are help engage cognitive operations when movement is occurring. So if you do take away the goggles, maybe you could have movement through space. I don't know how that would be helpful in connecting the person with the experience.
Yeah, so we have a couple of ways to kind of address that very issue. One is that the intervention team, the students, and some of our doctoral students are looking at technology in the older population specifically. So this is kind of part of their dissertation work. So one thing we're going to do is a stepwise approach, where we'll have them start out with small increments of like 3-minute virtual experiences and kind of build up to being able to withstand a longer, like a full church service, right? Because we understand that it can be a little disorienting initially. So we're going to kind of walk them through this graduated approach to being able to use the virtual experiences. And then we are going to ask that they stay seated initially and clear. We have a whole protocol for how they're supposed to engage with the technology, but we are going to ask that they stay seated, that they make sure that nothing's around, like I just hit this thing right here, that they're clear, that their surroundings are clear. The one physical activity that we do have built in is Tai Chi, and so they can do that, sit from a seat, or they could stand, but we're going to ask that they be in an open space where they're not going to hurt themselves.
So there is some.
And we'll be checking in with them every 2 weeks to see how they're doing and to be able to assess these types of things and make adjustments. Again, this is not a prescriptive intervention, so they're free to engage or to not engage in the various activities, and that would be part of us understanding what's really going to work and what's not.
That's great. Yes.
Yeah, hi, I'm Mindy Fain, and that was just a wonderful talk. I think that the concern about the ability of older adults to manage the virtual reality is a real one. And rather than, I'd love to think of a way that we can work with vestibular rehab things to make sure that they're not excluded in the future from virtual rehab, because that's a lot of the future. And so the idea that it's difficult is absolutely true, but maybe there's a way to engage a minimal vestibular rehab. You don't need a lot in order to be able to then manage virtual rehab. So maybe that's a way to make sure we don't further exclude older adults from exciting and important
Exactly, and that's what the pastor who we had the quote from was saying. He's like, I'm an older adult, I use virtual reality, I love it, right? And we just have this assumption that, oh, older people, technology, no, don't do it, they don't want it, But I'm like, well, let's try it, right? Like, we don't know until we try. And so that's why we have kind of this menu of options for them to engage in. So at a minimum, we want them to participate in the church services, because that's kind of the crux of what we're doing. But then they'll have access to all of these other things. They can come to DC. There is a field trip where they can come to DC. They can sit and binge chili bowl. And they can go through this historical conversation about what it's like to be in the South during the era of civil rights. And so there's a lot of great experiences that they can try, and we'll get to learn about what they like, what they don't like, what works and what doesn't work.
One of the things I really respected in the research too is this using these new technologies, even novel technologies, from a point of the assets that the community already has, leveraging an existing strength, their social connection, as a way to kind of further activate it. And I think I'm particularly interested in that part and how it could be applicable potentially in other communities that already have a strong bond as a point of beginning. So. And
thinking about the intergeneration connection, the pastor who has the virtual reality says, when my grandkids come over and they get on the headset, or then they're like, oh, hey, grandpa, try this out. And so we have built into our evaluation also to ask, did anyone else in your household use the technology? And then we'll be able to go back and kind of separate out, oh, okay, we know that someone else in the house was using the content, so that probably explains, maybe some of the activities. And then we can really look at how the family dynamic, how that may have played into it, and other things as well.
It's a shortcut to intergenerationality. I love it. There's an online question. Is that right? Yeah.
There is an online question, but I'm going to turn over to Dr. Insel real quick.
Yeah, great.
We have a queue.
Well, do we have time? Because I'd like to engage the online audience too. What I'm intrigued by is your comment that these are people who are already connected in that sense. And so how do we expand that to get to those folks who feel like there isn't the option to go to church, and make that happen for them? And I'm also intrigued by Lee's comment. Is it the headset or something else? And I think we have to look at that and be open to disconfirming, evidence. And what are the components? Because I was struck when you talked about mechanism in terms of loneliness. I have only gotten through the introduction, but Esther Sternberg is quoted in it, and it's John Cassiopo's book on loneliness. And I'm struck by the fact that in his situation, what he talks about, you can be lonely in a crowded room. So what are those pieces? And is it something that we haven't identified? But it's thrilling to think that we might be looking at this area. It's an critically important area, and thank you so much.
I'm excited for the larger trial that's going to get funded. And then we can look at all
Good
of
job.
these things.
Yeah. Well done. The online question, yeah.
This is actually such a great segue. So let me turn it over to our Innovations in Healthy Aging Council member, Mr. Tom Barnard. He's going to read the question, and I'm going to try to answer. It's not related specifically to this talk, but about all the information being presented in general today.
Thank you. The question comes from Ken Kennan. How would you suggest those of us beyond this network with serious interest in its goals and their effectiveness tap into information on these specific subjects between conferences?
Thank you. I think this also points to those of us in the room and joining us online, how valuable they're finding this content. So with the Innovations in Healthy Aging, we offer a speaker series, we have a newsletter, we are running we're promoting clinical trials. And for those of us in the room and online, please go to the website, and we'll also be following up over email. We'll be surveying you. And we want to make the annual summit and everything we could offer in between the summit as valuable as possible. And before you leave the stage, we just have one final question from Lee Ryan.
Great, yeah.
So again, I don't think it's actually a question, but it's a really important point following up on what Kathy said. So I am a psychologist, and I study aging, and many of the people in psychology in my department do. I think it's a really important point to make so some of the work that Matthias Mell, who is a social psychologist with us, has done has shown that it's not how much individuals talk to other people, it's the quality of the interaction. So being lonely in a crowded room so just the interaction itself is not enough. It has to be meaningful. Now you've built it in that it's meaningful for those individuals, but that's another totally important and key question is how do we build meaning into these interactions that thinking that you're going to take it to the next step away from the church, for example.
That's great, thank you. Yeah. Any last questions? A round of applause for Dr. Evans and Dr. Palmer. Thank you so much. Grateful for this research. The second presentation in this session in social isolation and belonging comes from Dr. Yumi Shirai, who is a neighbor to me at the University of Arizona, so I'm thrilled to be neighbors with her here at in Washington, D.C. She's an assistant professor and is the director of the Sonoran Center for Excellence in Disabilities, the Department of Family and Community Medicine at the University of Arizona. I know this space that she operates in called Artworks, which if you know of it at the University of Arizona, it's an incredible space where they're doing incredible things all the time with the community there, art projects, displays, and others. So I'm going to invite Dr. Shirai up to talk a little bit about exploring and identifying communities where I belong, arts-based, person-centered bookmaking workshop. Please help me welcome Dr. Shirai.
Thank you very much, Tyler. Thank you. Hi, Hi, everybody, and thank you very much for having us in the panel. And it's very exciting to hear about Kelly's program because it's all about connection and how we really can extend that connection. And Tyler and Sydney and Dr. Gubner, the power of arts are so important and effective. So I'm very, very grateful to have this presentation in this session. Thank you. So Tyler said this, so I'm good. And also I'm an affiliated faculty for the Innovation in Healthy Aging, as well as applied cultural art research at the U of A at the Graduate Interdisciplinary Program. So I also thank Innovation in Healthy Aging for the funding, for the seed funding to conduct our study. And then also Sonoran Center for Excellence in Disabilities that I belong to. It's a national network of University Center for Excellence serving for the people with intellectual and developmental disabilities. And then also our project partners and the core eyes. So Dr. Gubner, you saw Dr. Gubner on the video, Dr. Tomasa. So they have a different background on digital storytelling, Dr. Gubner, anthropological kind of viewpoint. And then also Dr. Tomasa, community engaged activities and evaluations. So having their support is very critical to me to have the critical lens to coming into the community work through, because I'm so embedded into Artworks, which is an art program and service program for people with intellectual disabilities. So I sometimes myself embedded in too much, so I need to step back to have more critical lens. So having the partner is so important. And I do have a graduate research assistant, Lucy, undergrads, Kim, Marissa, Aliyah, and Jordan, and we have a volunteer, Janice and Scott, on this project. And it's a small project, but takes a lot of people to have this happen. So session overview, I will go through, and I want to be respectful of the time, so I'm just going to go. So the population of intellectual disability, because it may be new population or unfamiliar population for some of you. So it is characterized by significant limitation in intellectual functioning and adaptive behaviors. So what does that mean? Intellectual functioning, so remembering things, thinking through the issues and problems. And then also you see the second picture, making relationship, having boundaries, some of the senses that we share, right? Sometimes we may feel comfortable next to each other, but maybe some may not be comfortable, or noise or sound. You see the air conditioning. And do you hear some similarity in the people who has aged and having the sensory input kind of compromised? And then also some function that's important to carry on the activity of daily living, which is you all are familiar with, so I wouldn't go through. And those conditions are initiated or originated age of 22 or younger. So it can be a wide range. It can be from before the birth to the age 22. So what are the unique challenge of aging group, particularly this group, because I worked in artwork program, which is an art studio and gallery for adults with IDD. And I have grown in this field in the past 25 years. I worked as a direct care worker, student, and then also as a staff member and director for the over 14 years. So what are the challenges? So clinical health conditions. Some chronic health conditions are heightened in this population, such as obesity, and constipation, other health issues, and then also other health conditions such as Alzheimer's disease, thyroid issues, and others are heightened in this population as well. And I don't go through those because if you go through each of those, it takes another hour of presentation. And despite of those risk factors, many of our folks are not included in the typical research, so health research programs. And what does that mean? And many of the general research, health research, reflect upon the policy, funding, program, and services in the community. So many of those services are created without the input from our population. What does that mean? No wonder why some of our population may not be included in those programs or may not be comfortable going there. So that's the challenge. And then also the aging issue. Aging means not bad. We are all aging. And then also our population are aging. And compared to 20, 30 years ago, our people are aging older. And oftentimes they outlive. Majority of them outlive their parents. The parents are the primary caregivers, right? Lifelong caregivers. They hit their own aging. They retire, pass down the primary caregiving role to their siblings or community caregivers. So what happens, right? So those are the issues that people face. And it also another big challenge for this population. They have lifelong conditions. It can be physical, it can be behavioral, it can be emotional, mental health. And that overshadows whatever they are coming up in the age-related health challenges. So the diagnostic overshadowing is the term that clinicians attribute those causes of the new symptoms to the lifelong conditions. We need to educate the health professionals as well as caregivers to identify those with the comorbidity of different conditions that they have. So this is an example. Casey, the story of Casey. I think it's very, it's hard to capture with the abstract term, but having the example may help. So Casey lived with her mother and many cats for most of her life. After the parents divorced when she was age 8. So at the age 40, she lost her mother. And at that time, she lost her family home. And also 13 living cats. One of her favorite cat was the black cat named Eunice. And she lost all of it at once. And the first year after her mother's death, she moved around for 5 different group homes or residential settings. So finally, she settled in one adult developmental home. She found a good caregivers, but 5 times within a year. Think about it, how hard it is. And turnover rate of caregiver in our field is critical, right? It's devastating. And knowing her life and without cat, without the house, how she felt during that time. And after she settled in her 40s, she started losing her weight. So the caregiver took her to multiple medical appointments, and she found out she newly developed the celiac disease that she never had it before, but that was newly developed in her 40s. But she still kept losing her weight, although she adjusted her diet. And between those times, though, she hurt her leg, and she went to the doctors, but she's walking on that hurting hood, right, leg. And they couldn't find out she had a broken bone over 2 weeks, but she's walking on it. So some of our population has very high tolerance in pain. That's not being addressed. And many of the older people as well, right? And then they cannot articulate what's wrong, right? I know something not right, but I cannot exactly tell you what's wrong. So maybe I withdraw from the activities, right? So that's how often happens. Even dementia, some folks who have infection, acute dementia, or Alzheimer's disease, the initial symptoms, we may not hear from them, right? We cannot really point it out. We need to do the detective work for them. And it's really critical to have the history of medical history and personal stories and baselines documented while the parents are around or someone who knows this person. So our project is to how we can reframe person-centered planning document with more visualized form, so themselves, the individual themselves can advocate and they can be the author, so they can identify what important information within that book. Because right now, person-centered planning is mandated for the folks who receive the state and federal services, but not necessarily individual themselves can find the information in the right places because it's all typed words. So as an art center, we implemented a lot of visual arts, even gestures in the curriculum. And majority of the content we have 8 modules are really connected to the person-centered planning. But I have one highlight with the roles and leader style. That's the part that I think the loneliness and isolation, I think this key part should be addressed in the person-centered planning. Because as a partner to make this book, their role and leader style connected to their communities are critical, right? We don't see them as we are serving them. They are the partner in making this document together to carry through their lifelong services, right? So how can we identify their leader styles and connections beyond just they are being served? That's the belonging, right? They have capacity and asset base. So, what is their talents? And talents is not enough. How they want to contribute, how they are connected to the community, those parts are very important. So I turned to Inclusive Art Practice Framework, which is developed by Dr. Fox and Markerson in the 2015. And as an art studio within IDD, we really up to their framework. They have a broader, very loosey framework to how we can manage mutual art project that we can do, people with and without disabilities. And they don't really make the steps within this framework, but I sorted out into 3 steps to really formulate my curriculum. So the first step is to set the framework and baseline so we can share. So we set the 8 content of this scrapbook making, but what would be our shared starting point, right? So the first module is communication and learning. So accessible format, how can we share and confirm where we are starting, what we are talking about, right, with the visual format. And the next step is having this material to make relationship and connection among peers, exchange some ideas, make more games, and physically involved so they can share the stories not just with words, but gestures and drawings. But to ensure they are trusting relationship, we document what has been said. That's the acknowledgement. What you said is, we heard you. We document those. That's really important. And that's the respectful time. It takes much more time than what we think. That's the reason we have volunteers and support from the students and others. And once we documented those important parts, we take a journey with an open mind and patience. So the patience means time and flexibility. And if they want something more, we provide them more. They can say the idea. They are the authors of their books, right? So we take time. So it may not finish in a week. We may take 3 weeks, right? That's okay. Any kind of forms can be, and we support them whatever they want to document their story in their book. So luckily, we have art staff members who can really guide them to illustrate in the way that they capture. And some of the typing and written words can be provided by supporters or family members, but having the picture or stickers that they picked, they can identify which page they can find that information they need. So the purpose of this project is that themselves, as an author of person-centered storybook, they can really identify and having the conversation of more in-depth information, not just one thing. I like football, so I'm the Cowboy fan. No, not just that. They have much more connection in the communities in their life. And how can we extend that? And that's so important because having that book, they can make connections. And then also the caregivers or supporter make connections with them. Oftentimes, I've been working with the artworks for the last 25 years. I still find out new facts about that person as I make this scrapbook together. And it's the amusement of myself, right? It's our work, but our journey with our artist. If you use the creativity in a conversation, you can discover something new in the moment. And so we recorded the pre and post kind of interview session to really capture their capacity to speak about themselves and their needs and their wants in the verbal format, structured interview workshop and then after the workshop. So we narratively, 5 more minutes. And then also we implemented the survey with the caregivers, their perception, what they think of their care recipient or adult with IDD, how much they can speak about themselves and voice their needs and want. So, how far we came along this project. So it's a process because the modules, we have 8 modules, but we didn't make those 3 steps from the beginning. So we implemented 4 modules with the Tucson Parks and Recreation, and we implemented it with them, and we got their input to see what kind of structure may work. Then we kind of solidify some of the worksheet that may be workable, and we discovered having a lots of logos and stickers, those are very helpful, and then also locally connected logos, right? So any of the Special Olympics logos, Tucson flags, or maps, and those kind of things are very important. They can have the actual connection and they see those things. And also the transportation, so we have Sanban in Tucson, so it may be different from DC, right? The transportation system here is different. So metro can be, or bus, I don't know what kind of transportation we use here. So we need to be locally adapted for those materials. And secondly, we implemented this with the Discapa's Borderland digital story through Sonora News Ed, and we translated it into the Spanish and English. It's nothing to do with the outcome of this study, but during that process, we really implemented how can we consent the participants in a comfortable way. The people with IDD with the consenting document, the 3 pages document reading through, is torture. It takes 30 minutes to go through reading through their consent. So we have teach back questions of the consent form, and we initially read through all of it. Then we had 5 questions at the end, whether they understood each content. No, that was not enough. So you need to go through 1 content and 1 teach back question, another content, teach back questions. That was more feasible. And then also you need to provide the visual form of what are the scrapbooks look like and an example so they understand what does that mean to be part of this project. So that was very interesting too. And now we have a pilot study with the Artworks folks and then also partner in Phoenix who has a large day program and residential programs. So with the partner, we are doing virtual format. So that's another technology part. And in Artworks, we are doing it in person. So we probably come up with different results, and we have a lot to thought out thing to do, whether the virtual format works or in-person format works, or do we see any differences in those? And so overall, the structure that we made up, those 3 steps really worked. But then we have some constellation to think through. And based on their capacity and language skills, and then also the capacity to write things down, some modules really needs input from the support person and the caregivers. And also some may take much longer time. So I thought the 8 modules go with the 8 weeks. No, it was nothing like that. And also some people get sick, right? So we need to catch up time to give them to catch up. Okay, and then also some people get tired. And then also we thought we can give them homework. No. This is a lot of work for them. So we really need to secure those time, respect that time to make it really full. And then also we really needed the one-on-one support that maximized the conversation making into the scrapbook. So that was really critical to have the artist staff member and volunteers to be having conversation one by one. But in order to do that, we need to train them in terms of individuals' behavior tendencies, their what comfortable barriers for them in terms of having conversation. So I have more to-do list in my list. We need to make those trainings for the future. And also having the study, we recorded the sessions, and Jenny told me how to frame, how to measure, and how to set up the videos and audios. But that is hard. If you are a practitioner and you never make the digital stories, I mean, I cannot frame the videos and I cannot consider any noises. It's really hard. So those partners are so necessary to go through together, because the power of visual art and digital format is so powerful to deliver stories. So my time is up. So I have so many things I really want to do in the follow-up. So of course I need to finish up some of the workshops, and then also evaluation and creating and finishing up the digital story with Jenny and Lynn Tomasa. But I have so much that I really want to do. So the facilitator guide and also volunteer training guide. And another part is developing a co-facilitator modules for the IDD co-facilitator. So some of the initial participant with the scrapbook participant can be a co-facilitator of these modules. So the peer member can be really encouraged and to be part of this project. So whenever I go into the classrooms, I bring my artist with me, because when I talk about preaching about the numbers and data, it doesn't really speak to my students. They can get sleepy in 15 minutes. So the partner, having the advocate partner is so important. So that's kind of my future, and I'm very excited to carry on this project, and thank you so much.
Thank you so much, Dr. Shirai. I want to invite up Dr. Margaret Nygren to help discuss. Dr. Nygren is an assistant professor of psychology and bioengineering at George Mason University, among many other roles.
I'm so totally not.
Yeah.
I have no affiliation with
Did I
George
make
Mason.
that up?
Yes, you did.
I'm sorry.
Instead, I have a different job, equally good, just not that job.
Thank you.
Sure. I'm actually the CEO of the American Association on Intellectual and Developmental Disabilities. And I also don't need to stare at my face. So can we find a way to... Thank you so much.
Yeah.
I also went old school with paper, and I don't have slides. So thank you very much for inviting me to participate today. In order to put some of Dr. Shirai's work into context in the field, in the research that's happening today in intellectual and developmental disabilities, I'd like to begin by fleshing out a little bit more of the diagnostic criteria for intellectual disability, because I'm not sure that's a population that you're particularly familiar with. So intellectual disability is one of a category of conditions called developmental disabilities, which means that they're lifelong and first appear during the developmental period or childhood. So intellectual disability has two other criteria. First, that the person has substantial limitations in their intellectual functioning. That's their sort of inherent capacity for acquiring understanding, using information. What it means is that their capacity has an upper limit. It's known, and it's lower than average. The second criteria is the person has substantial limitations in adaptive behavior, that is their ability to adapt to their environment through learning, analyzing, thinking symbolically, making informed decisions, and so on. So this capacity also has an upper limit that's known and lower than average. Now, all of us have an upper limit in both of these areas. It's just perhaps not known by us or those around us. We all have our unique pattern of strengths and weaknesses in how we adapt to our environment, how we look at the world. And that's also true of people with intellectual disabilities. It's a condition that is on a continuum of the level of impairment, and each person, I have to stress, has their own unique strengths and weaknesses. Conceptually, when we think about disability in our field, we talk about it as being a mismatch between the person's inherent capacities and learned abilities and the demands of the environment. So when we look at that gap between their capacity and what it takes to be successful in the environment, our goal is to find those strategies and supports that can fill the gap to increase the individual's functioning and success in their environment. A big area of research in our field is understanding the environmental demands across the lifespan, because our demands change from infancy to childhood to adulthood and then finally to older adulthood, and how we can fill the gap in general for people with disabilities, but also in particular for each person with disability, because they have individual strengths and weaknesses. So as an example, for most adults, we're able to meet our environmental needs for food and shelter by buying them with money we earn from our jobs. But jobs do more than just provide us with money. They're tied to a variety of social and personal meanings. For adults with ID, whether or not they actually are responsible for buying their own food and shelter, having a job as a thing can still address social and personal meanings. The status of being an adult, being someone that others can and do rely on, a person that makes a valuable contribution to their community. So an area of inquiry for us in terms of employment would be, what social elements signify that someone has a real job? And specific to the person, what kind of supports they need to fill that gap between their capacity and the demands on them in order to get and keep a job, so that they can have those social meanings that having a job can convey. So in practice, what we're doing, those people who are working to provide the direct supports for people with disabilities, they would look to fill the gaps based on the strategies that work best for the person, how they learn best, and so on. And that individualized approach is the basis of what we call person-centered, which is a long way to get to where Yumi started, the person-centered booklet that she was making. So enough context on that. Dr. Shirai's project is part of a line of inquiry that's common in the IDD research that concerns the meaning and value of one's identity or intersectional identities, and the concept of inclusion and belongingness. So identity and a sense of belongingness is very hard for people with intellectual disability who are not generally welcomed into many of the communities for which they share an identity. And so when we talk about belongingness in a group or community, it can be anything. Being a couple, being part of a family, employees of a company, being affiliated with a faith or particular house of worship, identity that's tied to sexuality, hobbies, particular abilities, like say being an artist, or good with computers. But I should also emphasize that when we talk about community in IDD research, we're not talking about segregated or closed systems like, say, an institution. We're talking about community in the broadest sense, in that we interact with multiple people over the course of our day. And as with the employment example, we're looking for the meaning of inclusion or belongingness. What are the characteristics of really belonging versus just being in the room? Someone talked about that earlier, being very lonely in a room for a group of people. How do we know and how do we feel that we belong? And for the person, what kind of supports do they need to get to the point that they are truly accepted and a part of the community? So Dr. Shirai's proof of concept research here with this project includes identifying identities and communities that will reduce isolation for the participants. It includes adults with and without intellectual disability, which is really important because now this workshop activity is not segregated or exclusively for people with intellectual disability. Kudos to you for doing that. That's really important. She also assigned all the participants an additional identity as author of their own life story. This is crucial because people with intellectual disability have so few identities that they call their own. And so it's very reinforcing that they are the author of their own life story. She used a series of structured activities to help them consider their abilities, their strengths, and their intersecting identities to help find their sense of belongingness. One challenge that Dr. Schreier mentioned in her presentation was that there was a range of abilities among her participants with intellectual disability, and some of the participants had pretty substantial support needs and needed that one-to-one support to be able to complete the tasks or fill the gap. I have to wonder, if such differences in support needs, the requirement of one-to-one supports, question for you, Yumi, did they have any impact on developing a sense of community in the workshop because of the support needs to complete the task? No? Okay, good. Another issue that you mentioned that I was really curious about was the differing primary purposes in creating the scrapbooks. I'm curious to know if what the differing purposes might have been. Also, if you think, if had a group that was sharing the same primary purpose, may have been more engaged in community building within your workshop. So those are my questions for you. Thank you.
Thank you, Maggie, for the fantastic comments and also the overview of the field of IDD and what's important in our world. And answering your question about the person who require one-on-one support, whether they are not engaged as much as the others, not really, because we allow them to use gestures and noise and words when they want to talk. So they feel comfortable enough to speak out, but then they may not be able to document it. So the documenting those what they've been expressed, it's so important to have the one-on-one. But being a participant of conversation and interaction, the level of their literacy or capacity really didn't matter. So that is a really safe environment. That's the step 2, that we make it happen to have more physically and visually engaged activity rather than heavily rely on the language that we speak. And the second one, the purpose of the workshop. So one of the group was focusing on creating a digital stories of their life. So which was not focusing on the expressing the support needs. So when you think of the support needs versus their life story, 2 different purpose, and some of the module weigh more on the others. So for the digital story folks, we really focus on the 6 modules, not much of the support needs part. And then the folks who may need more one-on-one support or a significant life support needs, we really need to extend that time to go through one by one with our checklist and stuff, so we can document that's unnecessary to maintain their quality of life and express those.
Thank you.
Are there other questions from the room for this session? And as Tara's going around, I have a question about the 8 sections that comprise the book, how you identified those 8, or if there are others in the research that, maybe we'll do, next time we do this, we'll add this area, or how you thought about those sections.
So, the person-centered thinking and planning, it's been in the field for long, long years in the IDD field. So majority of the contents are from many of the prior books that's in there. However, I added this leader style and then roles. That was important to make the connection and their strengths. The strengths and challenges, highlighting the strengths doesn't really justify their belonging and the connections. So it's really important for going through the leader style to how they like to be connected, how they like to contribute to the community. So that is the part that I really added into this module.
I also would love to invite our online folks to submit comments or questions, but if not, then we can also, any other questions?
Well, and I will also just say that I found myself in thinking about the research and in listening, desiring to want to have my own book for when I need to go see a doctor. These are the things I want to tell you. And so I'm interested too in how you feel, if there's potential for how this research might serve other communities
Yeah,
beyond.
so I was talking to the director of our local Alzheimer's Association, and this activity is really fantastic for the Memory Cafe as well as the typical population, because caregiver and the care recipient, both of them really enjoy having that conversation together. In fact, when we went to Nogales, the southern border of Arizona, the family member came in with the 2 individuals with disabilities, and they actually, each of them made up their own scrapbook. So it's not just for the person with disabilities. And I think, I forgot who mentioned this, the art is like a realization of what we know. We are passing the cactus all the time, right? But then we really intentively pay attention to. So how we can intentively attention to our connections and the community that's in our life, but we haven't taken that time yet, right? So it does apply for the individual who needs support, but it applies to us, for all of us. So all the students and the staff members who participated in the program really contributed and identified their culture as we go around this workshop. So I think you are right on. Yeah.
I need to come visit my neighbor more and make a book. Grateful for this. Thank you guys so much. Dr. Nygren, thanks for giving me a do-over on your introduction, and I will do this now. Dr. Nygren is the Executive Director and CEO of the American Association of Intellectual Developmental Disabilities. And thank you guys so much. Very much appreciate this conversation.
Thank you.
Thank you.